All right, so this is cardiovascular diseases, part 3. In this lecture, or this part of the lecture, we're going to talk about heart failure and peripheral vascular disease or peripheral artery disease and atrial fibrillation. All right, so here's our progression of cardiovascular disease again. So in this last section, we're going to talk about heart failure. So again, cardiovascular disease over time, arthrosclerosis, hypertension, then we have that coronary artery disease that we talked about in part 2 with angina and myocardial infarction, and then heart failure. Remember, back to the coronary artery disease, it's a blockage of the coronary artery. Okay, so CAD, but the outcome of those blockages is angina and myocardial infarction. We spent a lot of our time talking about those two diseases. All right, so pathophysiology of heart failure. First of all, there's two main types of heart failure: diastolic, which means that the ventricles can't fill, and then systolic heart failure, which means that the ventricles can't pump. Okay, so these are the two main types of heart failure. It's virtually impossible to have both. Okay, so both types lead to a decrease in cardiac output, but by different mechanisms. And we're going to talk about diastolic and systolic heart failure. Each type has its own pathology. Both, as I said, result in a decrease of cardiac output. So in one, can't fill, and in the other one, it can't pump. Okay, so I have a picture there kind of depicting a little bit about what the heart looks like with these different types of heart failure, and we're going to talk about each one. All right, so first of all, a fundamental concept, okay, about like heart physiology and why heart failure, why we're so concerned about heart failure is ejection fraction. So you really need to know what ejection fraction is. It's really a fundamental concept. Ejection fraction is the percentage of blood in the ventricle that gets pumped out with each heartbeat. Okay, so the ventricle fills, how much ever that ventricle pumps, so the amount of blood the ventricle pumps out of the heart is the ejection fraction. It indicates how effectively that ventricle is pumping. And just as heart failure alludes to, okay, if the ventricles can't pump that blood out, our ejection fraction decreases. Okay, so percentage is a key word. So whatever part of what fills the ventricle, the ejection fraction is measured in a percentage that gets pumped out. Okay, and this percentage is the ejection fraction. Ejection fraction is an indicator of how effective the ventricle is pumping, okay, as I just mentioned. So in a healthy heart, okay, let's just say that your ventricle holds 120 milliliters of blood. Okay, the stroke volume, which is the amount of blood pumped out with each ventricular contraction, your stroke volume is the actual amount of blood that's pumped out, okay, or 70 milliliters, because remember, ejection fraction is a percentage, okay? So left ventricle can hold 120. Our stroke volume pumps out 70 milliliters. So we divide 70 by 120, and we get 0.6, okay, which is an ejection fraction percentage of 60. So 40, okay, like my little diagram at the bottom, if we have a left ventricular ejection fraction of less than 40%, that means our left ventricle pump is very weak. Okay, so a couple of important things here. Let me just review this slide. Ejection fraction is the percentage of the blood in the ventricle that gets pumped out. Okay, so percentage is the key word. Stroke volume is the actual amount of blood that gets pumped out with the ventricle contraction. So it's like milliliters. So to find the ejection fraction, an example, 120 milliliters, okay, divided by 70, okay, or 70 divided by 120, I should say, gives us 0.6. So the ejection fraction is 60%. All right, so here's the pathophysiology of systolic heart failure. All right, this is the classic pathway. It starts with arterial sclerosis. Okay, so as the heart, okay, is pumping and trying to pump blood past some type of blockage, okay, because from arterial sclerosis comes atherosclerosis. So as the heart's trying to pump past a blockage from atherosclerosis, the heart muscle actually gets stretched out. Okay, those heart fibers get stretched out because they try to accommodate all of the extra blood and fluid that's left behind, okay, in the heart from not being able to push or pump past the block. So with that extra fluid getting left behind, it gets stretched out and loses elasticity. And that wears out the ability of the ventricle to actually pump the way it used to. And when this happens, okay, with this stretching of the ventricle cardiac fibers, the ventricles can't empty or can't pump all of the blood out, okay, all of the blood that it has. So it kind of follows this pathway that's listed here on the slide. So it starts with arterial sclerosis. Then we have an increased vascular resistance, okay, or an increased afterload of the heart. Because of that, that's almost, you can kind of deduce that that's like that atherosclerosis. The myocardial fibers and the wall get stretched out. That ventricle loses its elasticity. It can't contract effectively, so the chamber can't empty. Some other causes of heart failure are also listed here on your slide. Things like infections like mononucleosis, also Lyme's disease, rheumatic fever, okay, myocardial infarction, okay, aortic stenosis, okay, can also cause heart failure. If there's dead tissue in the ventricle wall after an MI, that dead tissue often gets replaced with collagen and it can't contract. It becomes very stiff and it can't contract as it should. So that can lead to systolic heart failure. Actually, an MI can severely weaken the heart, okay, because of this dead cardiac muscle getting replaced by collagen and can be a cause of heart failure. When we talk about systolic heart failure with pregnancy, it's usually hormone driven, okay, and that hormone driven, we call that hormone driven cardiomyopathy because there's a huge surge of estrogen and that can contribute to poor cardiac function. Alcohol also is directly toxic to heart muscle. So if a heart is consistently exposed to the toxins, then it goes through kind of cycles of cardiac cell death, which occur. And this causes elastic fiber to dissolve, the heart can't pump. So if somebody chronically ingests alcohol, it really makes it hard for the ventricle to keep contracting because of this toxicity of the alcohol to the cardiac muscle. And then COPD can cause pulmonary hypertension from blood flow to the right ventricle and into the lungs. In this, we have a high afterload in the pulmonary circuit, and it takes a lot of force for the right ventricle to push past it. Okay, and then you have a very low right ventricular ejection fraction. All right, so those are some other causes. So we have the normal pathway that can result in heart failure, starting with arterial sclerosis and ending up with that ventricular chamber not being able to empty, or systolic heart failure. And we have other causes also for that systolic heart failure. Now, here's diastolic heart failure. With diastolic heart failure, we have a preserved ejection fraction. Okay, so remember the ejection fraction, if it's greater than 40, it's okay. So with systolic, we have that decreased ejection fraction, or the decreased percentage of the blood being pumped out of the heart. So this could happen similarly, okay, to systolic, but instead of having muscle fibers and ventricles that are stretched out and thin, we have ventricles actually bulking up. So a diastolic heart failure is complicated and really not well understood, but at some point there's almost a split that happens, and we develop either systolic or diastolic heart failure. In diastolic, the ventricle becomes very thick, very stiff, and from the diagram over here, we can see how the chamber in the left ventricle is really diminished and the chamber does not fill up. So there's really not enough blood can get in. All right, so we have more of a filling problem because of this thick wall related to the diastolic heart failure. How can you have heart failure if the ejection fraction is normal? Okay, like we just talked about in diastolic. A hypertrophic, left ventricle, or very large left ventricle, can only hold about 70 cc. A normal left ventricle, as we said, can hold 120, or about 120 cc's. So if you start off with low volume and they can pump out about half of that lower volume, then the ejection fraction is not low. It's pumping out about 39 milliliters. Now, 39 milliliters isn't enough volume, for the demands of the body. It's not enough blood being pumped out of the heart. However, if we do our math, 70 or 39 divided by 70, we actually get an ejection fraction of 55%. Okay, so it is above, we have a high ejection fraction. However, it's still heart failure. There's not enough blood being pumped out of that ventricle, because of the hypertrophy and that very thick ventricle wall. So it doesn't supply enough blood to the body. Heart failure really becomes a two-way problem. We can't push blood forward to get out to the tissues, of the body, and the tissues become ischemic. But we also can't clear the blood that comes in, from behind, so we end up with congestion behind the heart, or in the pulmonary circuit as well. So we have blood that can't come in, and we have blood that can't go out. If the left ventricle fails, our peripheral tissues don't get enough blood flow, and they become ischemic. So our kidneys, we develop kidney cardiorenal syndrome. If the kidneys don't get enough blood flow, they stop filtering the blood. On the back end of left ventricular failure, we have blood pooling in the pulmonary circuit, so we get pulmonary edema. So that's kind of what this slide talks about. It's a two-way problem. Can't push blood forward to the tissues, we get ischemia. Can't clear blood from behind the heart, so we get congestion. So if it's in the left ventricular, we have failure of the left ventricle. Our peripheral tissues become ischemic, because we can't push blood out, and we have backup into the pulmonary circuit. If the right ventricle fails, we end up with pulmonary tissue ischemia, which is very rare, because um, um, generally the issue is the blood stays behind in the pulmonary circuit, and we end up with a lot of edema. But the bigger issue in right ventricular failure is we get a backing up of fluid other places in the body. Okay, so sometimes we can get pulmonary tissue ischemia, but the bigger problem and the more common problem is we have this peripheral edema, or blood and fluids backing up in other parts of the body. So left ventricular, if the left ventricle fails, we get congestion in the lungs. If the right ventricle fails, we get congestion in the rest of the body. All right, so these are the three main complications of heart failure. First of all, we have acute pulmonary edema. And this is because fluid buildup in the alveoli happens, okay, with that ventricular failure, and we can't get gas exchanged. So we treat acute pulmonary edema with IV morphine, IV Lasix, and we also give high flow oxygen to really get that oxygen into the lungs and as much of it into the bloodstream as possible. IV morphine helps dilate the pulmonary circuit, and it takes some pressure off of that pulmonary circuit as well to help the heart pump better. IV Lasix, of course, removes fluid from the body. And then we talked about the oxygen. Cardiogenic shock is a lack of tissue perfusion, and it's caused by very poor cardiac output. Okay, so very poor ejection fraction and oxygenated blood coming out of the heart. Cardiogenic shock has a very high mortality, even with good treatment. Okay, so cardiogenic shock has a very poor or very high mortality rate. Patients must be in the ICU if they have cardiogenic shock. And then cardiorenal syndrome, I alluded a little bit to this, but this is the loss of glomerular filtration pressure flowing from the kidneys, because if the heart's not pushing the blood forward enough, it's not keeping that filtration pressure up, so that those nephrons will eventually just shut themselves down. Because of the nephrons will shut themselves down because there's not enough pressure, okay? And if there's not enough pressure of the heart pumping, okay, to keep that pressure up in the kidneys so that it can filter the blood through. So often patients with cardiorenal syndrome will require hemodialysis. So I want you guys to fill these out on your own. Use your textbook. Okay, you probably know most of these, how to answer them already. We've talked about some from this lecture, but take these from your note and from the book and just fill it in. Signs and symptoms of left versus right. The signs and symptoms of heart failure listed can really limit the quality of life and the functional status of patients. Okay, so all those signs and symptoms that you got from before can really limit the quality of life and the functional status. We sort of summarize how bad the symptoms of heart failure are, and how they affect physical function according to these class standards. Okay, so this is the standard way of saying how bad someone's heart failure is in terms of a patient's ability to function. So class 1 here on the slide, all right, is their patient's pretty healthy. They have no limitations. They really don't have any symptoms, but they have heart failure. Class 2, these types of patients are a lot of those that we have living in the community. They're comfortable, okay, not too many symptoms, but once they get up and start moving around, they begin to have some shortness of breath. Okay, so comfortable at rest, but some physical activities causes shortness of breath, symptoms of heart failure. Okay, and they have slight limitations. Class 3 people really can hardly walk out the door without being short of breath. Okay, basic movement causes shortness of breath. People in this class are in and out of the hospital a lot. Okay, that class 3. They're still pretty ambulatory, but it really doesn't take much to make them ill. Class 4, okay, people, okay, or individuals in class 4 stage of signs and symptoms of heart failure, or remember how bad the symptoms are of heart failure that affect their physical function. These class 4 individuals can't do anything. They have end stage short of breath, even at rest. At this point, a lot of patients often choose palliative. When we start to discuss palliative care and possible end-of-life issues, the conversation really needs to start with patients in class 1 or class 2. That's when their thinking is most clear, when we can really have those good conversations about what they want at the end of their life. We don't want to wait until the end stage because we don't always get a good picture of what the patient may have wanted because the symptoms are so involved and so aggressive, function is so limited. So anytime we do palliative care, conversations, end-of-life issues, we always start early in a disease process. With heart failure, it's in that class 1 or class 2. All right, so know those classes of heart failure and how they affect function for your exam and also for NCLEX. Now let's walk through this case study. MO is a 64-year-old Hispanic female who presents to the emergency department with shortness of breath that started about 3 hours ago. It's worse with activity and with lying down. She denies chest pain and nausea. She has a history of acute MI 2 years ago and had 2 stents placed. She also has HLD, hypertension, coronary artery disease, T2 diabetes, and aortic stenosis. Both of her patients had heart disease and died at a young age of heart attack, she thinks. Her medications include simvastatin, okay, at a regular dose, lisinopril at a regular dose, hydrochlorothiazide, aspirin, and metformin. Now, let's just go through these medications really fast. Simvastatin, okay, is a statin medication, okay, to lower cholesterol. Lisinopril is an antihypertensive. HCTZ is hydrochlorothiazide, which is a diuretic. Aspirin, of course, is an antiplatelet, and metformin is a diabetic medication. So you need to know medications according to their generic name for NCLEX. All right, so the patient's vital signs in the emergency department were as reading there. Upon exam, she was sitting upright on the emergency department gurney. The patient appears anxious. She's in acute distress with peripheral cyanosis. She's got fine crackles in all lung fields, labored breathing. Her accessory muscles are being used. She has an S4, okay, and an S4 sounds like Tennessee, and it really means a dilated left ventricle. So if you hear something when you take an apical pulse or listen to heart tones, an S4 sounds like Tennessee, Tennessee, Tennessee. Kentucky is an S3, okay, and it sounds, I'm sorry, an S3 in an older adult sounds like Kentucky, 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 okay? This is Tennessee, Tennessee. She's in regular, she's got a regular sinus rhythm, a little bit tacky on the monitor. The patient has a harsh systolic grade 4 murmur. Her peripheral pulses are 2+ with 3+ hitting edema to her bilateral feet and ankles. Capillary refill is 6 seconds. Her abdomen is obese, non-tender, and her bowel sounds are hypoactive. All right, so a couple of takeaways from this exam and your physical exam and then taking her history is that she has respiratory problems but also she's got a lot of congestion in her periphery along with poor perfusion, right? Okay, she's got that edema. She has the murmur. Her heart, she has the S4. Her capillary refill is elevated. Okay, she's got those freckles in her lung field, the shortness of breath, the cyanosis in her periphery. So she's got a lot of extra fluid on board, and she's not circulating enough oxygen to her tissues. Also, her bowel sounds being hypoactive. So, the gut isn't getting, a lot of blood flow as well. All right, so we send the patients for diagnostic tests, and we get a 12-lead EKG. All right, so the 12-lead EKG says that the patient is in sinus tach with a ventricular rate of 114, and she has left ventricular hypertrophy. The telestrip is down here at the bottom, and it does show a nice sinus tach rhythm, and the P waves are very close together. The chest x-ray was ordered, okay, and the results show cardiomegaly. So if you see like this white hazy area here, the heart goes all the way over to the left side, and it really shouldn't go over that far into the lung field. These, of course, the blackened areas are the lungs. Okay, air always shows blackness. Tissue is more white. So cardiomyopathy, this is a very, very large heart. It should go probably to about, mid-clavicular line is where the heart should be. All right, there's also diffuse pulmonary congestion in her lungs, kind of these little areas down here. There's a small right pleural effusion. Okay, also noted here, kind of in this area. Here's the little infiltrate. Okay, for the diffuse pulmonary congestion. No infiltrates are noted on this chest x-ray. Okay, so infiltrates mean, that there's no signs of pneumonia that are causing her shortness of breath. So the infiltrates, we would look for different pneumonia. So again, the little gray spots down kind of here at the bottom is that pleural effusion. Okay, and there's diffuse pulmonary congestion kind of throughout, these spots in the lung. So the echocardiogram is here. All right, so it does show a left ventricle that's dilated, and that's marked by the letter A. Okay, so her left ventricle is very dilated. There's a 20% ejection fraction. Her right ventricle has a lot of filling pressure, and then she has moderate aortic stenosis. Okay, so the right ventricle pressure is high, so that we know that the ventricle is not emptying, okay, as well as it should. Okay, so that heart isn't pumping effectively. So this is interpretation of different diagnostic tests: the EKG, the chest X-ray, and the echocardiogram. So then we go ahead and we monitor her labs. So here are her lab readings. So she's got a little bit of a low sodium, and that can be from the diuretic that she's on, the hydrochlorothiazide, or from dilution of the blood. So she's got a lot of fluid on board. Okay, she's got lots of fluid. So either sodium because she's got too much fluid, or sodium because of the diuretic. Her chloride is low, but remember, chloride is consistent with sodium. Okay, from your nursing 210. Other labs, her CO2 is low. And this is really a critical point. The CO2 in the BMP is not like the PCO2 of arterial blood gases. Okay, so you need to really differentiate that. That's a critical point. When we do a CO2 and a BMP, it's not like that PCO2 that we would draw. Here in a BMP, it's more like a bicarb. Okay, so there's a lot of burning up of those bicarbs in the blood because the patient is very acidotic. And so that's a real critical point to keep in mind. BUN and creatinine are high, so now the kidneys are not filtering as much, okay, which is confirmed by the glomerular filtration rate also here on the slide. So the patient is really getting some pulmonary ischemia. The pressure, it's the heart isn't keeping that pressure up to the kidneys, so we're going into a little bit of that renal failure related to heart failure. Glucose is consistent with diabetes. There's no cell death, so she has not had a MI because her troponin level is normal limit. And then also her basic natriuretic peptide is also very, very high. Okay, so this is a test that we do to confirm heart failure. So in this case, her BNP is very elevated. So back to the case study, okay, when you're looking through the case studies on a lot of these slides, what's the important information for you to take away? So we went through the health history, the physical exam, and then you read the diagnostic tests in the lab work, and it helps determine exactly what's going on or what the diagnosis for your patient would be. So when a patient comes in to the hospital or into the ED with symptoms of heart failure, we need to get labs. Okay, we need to get a BMP and a CMP, a basic metabolic panel or a complete metabolic panel. We need to do a CBC with differential, and that's to rule out infection or anemia. We need to get a B-type natriuretic peptide, that BMP, that we talked about, that tells us the amount of heart failure that the patient is in. We should always rule out an MI, okay, so a troponin level, especially if someone comes in with shortness of breath or is short of breath. And again, back up to the BNP, the only reason we do a BNP is for heart failure. We should also make sure that a 12-lead EKG is ordered because we want to check for those ST segments. We need to get a chest x-ray to look for infiltrates or pneumonias causing the shortness of breath. Fuzziness, okay, on a chest x-ray, remember, is positive for pulmonary congestion. Echo is an echocardiogram is also very important to see the ejection fraction of the heart. Okay, so it's a test that we usually always order for heart failure, and it can tell us what the ejection fraction is. And then a stress test can be done once the patient becomes stable and they're comfortable. We usually only order a stress test if their troponin level was elevated when we draw the lab. So we do that to kind of rule out if they have coronary artery disease on top of heart failure. So medications for heart failure, okay, are those listed on the slide. So we give IV or PO Lasix. IV is the preferred route initially, okay, but then we can convert over to PO. With Lasix, we want to give the least amount possible to get the best response. Okay, once we get that best response, that dose, once it kicks in at the best response, then we keep that particular dose. We use a potassium-sparing diuretic oftentimes, like maybe aldactone or spirolactone, because Lasix also dumps out a lot of potassium, okay, or it depletes potassium level. So spirolactone will get more fluid off without depleting potassium. Okay, so sometimes we'll have Lasix at first and then switch to aldactone, sometimes both together. It's going to depend, but they both are diuretics that we use for heart failure. Just know that Lasix will deplete the body of potassium. Okay, so a lot of times if patients have Lasix, they'll be getting a potassium supplement as well, which I have listed here on your slide. Dopamine, okay, is given if they're in cardiogenic shock, okay, or if there's issues related to cardiogenic shock, or norepinephrine, okay, to help with the contractility of the heart. All right, we talked about potassium replacement because of the Lasix, but also if they have a low potassium or magnesium, remember that can affect the heart conduction system. So we do need to replace those. And that's one of the reasons why we also get the BMP, the basic metabolic panel, to check those potassium levels. We need to order oxygen, okay, at 2 liters to start. Okay. These patients may also need BiPAP, okay, for respiratory support. We need to increase the oxygen getting into their bloodstream, circulating to the tissues. A Foley catheter is often inserted to monitor the response to the diuretics. If they have a lot of fluid on board, we really need to monitor the intake and the output. So Foley is put in to monitor the output. Daily weight are important to take. If the patient has, an increase of a couple pounds a day or 5 pounds in a week, then that could be indicative of heart failure. So we will go ahead and make sure that we weigh the patient daily, or the patient at home will take daily weight. Strict intake and output. A lot of times we also have these patients on fluid restrictions, and we do not give IV fluids. So we may give medications IV, but no IV fluids running. Patients can be up as tolerated, usually after 24 hours of stabilization, and we closely monitor those electrolytes. So with someone coming in with acute heart failure, we want to do the things, the medications, the diagnostic tests and things. And the patient in the case study that's coming in, that's somebody with acute heart failure. Okay, so that's the type of patients that will present. All right, so on the previous slide, we start with those types of things. Okay, and then we go into more of our monitoring, okay, and assessment. We want to assess these patients all the time. We need to know that their heart is pumping better, okay, with our treatment. So we need to watch things very closely. So we want to watch for any new worsening or bettering complications of heart failure. We need to do really good cardiovascular and respiratory assessments with our lung sounds, making sure that all of the tissues, especially to the extremities, are perfusing, that the edema is getting better. Cognitive status is extremely important in heart failure patients because confusion is often the first sign of poor perfusion, or that the brain is lacking oxygen. Okay, if the brain's lacking oxygen, then the patient will become confused. Again, we want to make sure that the patient has a daily weight. We want to continually monitor intake and output. They should be on a telemetry, okay, monitoring their heart rhythm. We want to always be monitoring their energy level, and then for any angina or anginal equivalent. All right, so these things are also really important for people with heart failure, exacerbations, or people that come in acute heart failure. So we want to monitor those things that we did on the slide previous, perform, and then teach. We want to make sure that they're in a nice, calm, quiet environment. All right, for the diet, we want to make sure that it's low sodium, or they're in a sodium restriction, because they're going to hold on to a lot of fluid, okay? And sodium also will cause the body to hold on to fluid. So we want to make sure that we have that sodium restriction. Also, a fluid restriction since the patients are in fluid overload already. Head of the bed can be elevated. That helps with breathing, helps them expand the lung field. Elevating their legs during the day is important because of the peripheral edema and gravity. If the patient, if their legs are always dependent, then gravity will pull that fluid towards their feet. So by elevating their feet and also applying those TED hose or SVD boots, it'll really help get rid of that fluid in the legs because the TED hose and SCDs will compress the venous circulation. Elevating the legs will help gravity, okay, not pull the fluid down, but help, use gravity to our benefit to get that fluid into like the venous circulation and pumped back through the body, decreasing the edema. We want to make sure that we get the patients up and walking. Okay, so we want to, bed rest until stable, but then up with assistance, get everything kind of moving around. Bedside commode, okay, so the patient can get up to the bathroom quickly, especially if they're on an increased Lasix or aldactone, or we can have a Foley catheter put in. In the acute phase, these patients are very, very sick. Okay, patients in acute heart failure or that have had an exacerbation of acute heart failure, they're very sick. So we don't want to overload them with a lot of information. We want to perform these things and we want to monitor. But eventually we do want to start teaching. These things are very important to help not have the patient go into exacerbation or lessen the symptoms of the heart failure. So we want to make sure we instruct on the fluid restriction of 2 liters of fluid or less a day, to report any angina or those anginal equivalent events. Fall precautions are very important. Some of the medications might make them dizzy, but also they need to allow themselves time to get up to the bathroom, okay? Because once Lasix kicks in, it usually kicks in very fast. Instruct any side effects to the medications, okay? Positioning, all right, to sit upright or elevate the head of the bed to help with shortness of breath and to help with oxygen demand is good. We want to start talking about advanced directives and offer lots of reassurance to the patient. Lots of reassurance, through even these exacerbations, and lots of reassurance afterward with our teaching. In the chronic phase, okay, so those things that we talked about, the case study, somebody coming in, the interpretation of the diagnostic tests in the labs, and then the things that we would order, okay, to check for the exacerbation of the heart failure, the monitoring, intervening, and teaching things for the acute phase. The chronic phase, we do things a little bit differently. In the chronic phase, there's lots of meds, okay, that we provide. ACE inhibitors, okay, help prevent cardiac remodeling and hypertension. Okay, we talked about that in the first lecture. Okay, we talked about Lasix and aldactone already. We can use beta blockers to decrease overall work of the heart. And then I have, for those ACE inhibitors and beta blockers, I have some of the names of those that we use. So make sure that you know the names, like the ACE inhibitor, lisinopril or losartan. Okay, for beta blockers, the coerg or the toprol XL. We can also provide nitrates, especially if they have pulmonary hypertension or if they have chronic shortness of breath or activity intolerance, like an IMDR. We provide aspirin for to decrease the platelet aggregation, and digoxin. Okay, digoxin has been around forever. We use it exclusively to get the ventricles to contract more forcibly in heart failure. It does slow the heart down and it strengthens the heart. So that's kind of the action of digoxin. So in diastolic, we need the ventricle to relax, okay, and not squeeze, okay. So we don't use digoxin in chest tests. All right, and we also monitor labs. All right, so we get a BMP every 3 to 6 months. Digoxin levels usually once a year. A lot of times we get a 12-lead EKG every year, and then frequent follow-up with the cardiologist. All right. So, for monitoring of chronic heart failure, one of the most important things to teach the patient with chronic heart failure or that chronic management of heart failure is to weigh themselves daily. Okay. This is going to be the first clue that there's too much fluid on board. All right. So, we need to make sure that the patient has access to a scale, that the weight is done at a consistent time every day, that they have no clothes on, and then when to call their cardiologist. So if the weight gain is 2 or more pounds in 24 hours or 5 pounds in a week. We need to make sure that we have the patient or we monitor the patient for signs and symptoms of edema, of shortness of breath. We teach on the medication side effects, things such as dehydration, orthostatic hypotension, or lightheadedness. We monitor for falls with this. And also for dig toxicity. One of the first signs of dig toxicity is nausea and vomiting. Also GI upset, a feeling of indigestion. A late sign of dig toxicity is a heart block, okay, or seeing green, yellow halos around things. Okay, so we make sure that we know and that the patient knows of those signs of dig toxicity. And then we should keep an eye on the patient's mood, endurance, and functional status, okay, to see if there's a downturn in any of these things. A downturn in any of these, the mood, endurance, or functional status could mean that the heart failure is not doing so well and they might be going into an acute exacerbation. So, with chronic heart failure management, it's really important that both the nurse and the patient be on the same page. Okay, so the ultimate goal is really to avoid hospitalization and increase quality of life as much as possible. We really need to encourage physical activity, and cardiac rehab is really a great way to do that. And cardiac rehab will prescribe an exercise plan that the older adult will follow. Um, and it also cardiac rehab will also provide other things like diet education, stress management, smoking cessation, and medication instruction along with an exercise program. If the patient is in cardiac rehab or if they're exercising, they should really stop the activity if they start to have symptoms, and that's kind of like their maximal level. Exercise for chronic heart failure management is very helpful. The 5 things that cardiac rehab focuses on is there on the slide for you, the little picture. It's also important when we talk about management of heart failure is to limit sodium, those fluid restrictions, less than 2,000 cc's a day, to elevate their legs during the day, apply TED hose, and have emotional support as well as a referral for cardiac rehab, as I said. So the same things with the fluid restriction, the elevating the legs, the TED hose, same things we've talked about already. So these guys are in cardiac rehab working on their exercise. Cardiac rehab, again, is really, really effective And everyone with heart failure should really be in the program and involved with cardiac rehab, especially if they're in stages 2 and 3. It can really make the biggest difference in rehospitalization for the patient with chronic heart failure. But the patient needs to stick with it. And adherence, unfortunately, sometimes is very low for a cardiac rehab program. So then the last category is to teach. Okay, so nursing interventions have to do with teaching chronic heart failure management. And we need to teach the things that are listed on the slide. Again, our goal is to avoid hospitalizations. Okay, we can teach them what they need to know. Um, they should be able to self manage different things on their own. They need to avoid those triggers. We need to instruct them when they call for help, when they would call their cardiologist, or when it's emergency. It is easy to trigger a heart failure exacerbation. So avoiding those triggers and when to call for help is really important. It could be as simple as like one extra meal at McDonald's. For the patient may feel like they're going to treat themselves, so they're going to go to McDonald's and have just one meal this week, but that could trigger a heart failure exacerbation. So it's really important, again, that we teach about the disease, the triggers, the treatment plan, resources, provide resources, identify or break down those barriers, such as access to transportation, um, access, the grocery store for food, access to an exercise plan, managing stress, all of the things that we have talked about. So if we teach the patient, they can better self-manage their symptoms and their disease process, and ultimately we can avoid hospitalization. So these are the medications that patients with heart failure are on, especially with chronic heart failure, and how we would manage those. So we have Lasix, which is a thiazide diuretic or loop diuretic, and digoxin. So remember we talked about Lasix already. It can cause dehydration because it is a diuretic, and it can also cause low potassium. So it's important that we encourage foods that are high in potassium, and also monitoring their potassium levels. Low potassium can also cause dig toxicity. Another medication that the patient is on is digoxin. With digoxin, patients need to check their heart rate for a minute before each dose. Okay, so we need to teach on how to monitor their heart rate, how to count, for 1 full minute. And if the heart rate's less than 60, they need to call their cardiologist. Talk to and instruct the patient on signs and symptoms of dig toxicity. They're listed here on the slide, but I did talk about them on one other slide as well. Not to take digoxin at the same time as taking antacid, so to split those 2 to 4 hours in between, and it has to do with absorption. Okay, and digoxin should be taken at the same time every day. Also for diuretics, remember that diuretics and Lasix especially has a half-life of about 6 hours. So before bedtime, we need to make sure that we give that Lasix much earlier, or 6 hours or more before the patient would go to bed, to prevent them awakening at night to use the restroom. All right, so let's move on to peripheral artery disease. Okay, so peripheral artery disease is virtually identical to coronary artery disease, and it stems from atherosclerosis in the peripheral arteries instead of the coronary arteries. Most people with peripheral artery disease also have coronary artery disease because they really go hand in hand. Peripheral artery disease can cause severe symptoms, especially severe symptoms including occlusion of blood supply to the limb, and then patients needing amputation. Peripheral artery disease has a pretty dramatic outcome. okay, if it's left untreated and blood circulation isn't maintained to those limbs. The three most common arteries that peripheral artery disease affects, okay, or atherosclerosis develops in, is the femoral, the popliteal, and the brachial artery. But the brachial artery in the upper extremity is pretty rare. If we do see peripheral artery disease in the brachial, the patients usually have um, peripheral artery disease along with some other autoimmune or some other clotting disorder. So as the lumen narrows due to atherosclerosis, the distal tissues lose blood flow, and this happens usually over a long period of time. So it's longer time frame than coronary artery disease. Coronary vascular disease then accelerates faster because the arteries are smaller. Peripheral artery disease vessels are longer, so that's why coronary artery disease has a much quicker progression. Chronic ischemia happens because of that longer period of time, okay, of the occlusion of the arteries and the blood flow. So chronic ischemia does happen. Signs and symptoms of PAD, peripheral artery disease, are losing leg hair. That's because hair cells don't get that oxygen. They slowly lose their function. Those hair stem cells die. Okay, so patients lose their hair. The toenails are able to get rid of a lot of waste, so they become very thick and yellow. Both of these things are very common in patients with peripheral artery disease. One similarity in peripheral artery disease and coronary artery disease is that the muscle oxygen demand is or an increased need for oxygen demand in the muscles of either in the extremities or in the heart muscle is present in both. So if someone isn't active, they won't have a very high oxygen demand. Remember, we talked about this with angina. So they won't have a high oxygen demand, they'll have no pain. But when the patient becomes much more active, they have a higher oxygen demand, the patient starts to have pain. So if peripheral artery disease affects the lower extremities, the patient's going to have leg pain. If it's coronary artery disease, the patient's going to have chest pain. So this slide really just is a side-by-side comparison of coronary artery disease and peripheral artery disease. Excuse me. They are almost identical. Right? And it's the same pathology. So these toenails here on the slide that you guys are looking at right now are called ram horn toenails. And this is a pretty extreme case, although if you work in long-term care or after you've been a nurse for a while, you will see even more extreme cases than this. And this is very common with peripheral artery disease. Those toenails become very thick, very discolored, and they grow kind of all wrong and wonky. A lot of times, these ram horn toenails cause infections and they can harbor yeast. So we talked about some of these signs and symptoms of chronic ischemia, like the loss of leg hair. The skin also can become very cool and dry. There's weak fetal pulses, delayed capillary refill, and those are all because of the blood flow to that extremity is lacking. Okay, because there's the plaque buildup and stuff in those arteries. Also, the foot can be very pale when elevated. Okay, and especially if we elevate it above the heart. And this is really a classic sign. And it's due to blood flow to the foot is usually done by gravity. So when our feet are dependent, okay, or down, gravity's kind of pulling that blood down, and the foot gets very purple, very red in color. Okay, and once we elevate the feet and they don't have that gravity pulling that blood flow down to the extremities, our foot becomes very pale. Okay, so pale when we elevate it. It can be a classic sign of peripheral artery disease. There's also a burning pain that can happen during sleep. And the pain isn't well explained, but it may be due to neuropathy. It may also feel like pins and needles. Okay, so burning or pins and nails, that numbness, the tingling. Ulcers can form on the top of the feet or in between the toes. And this is due to the arterial insufficiency of the blood flow. So it's important when you're diagnosing or when you care for somebody with ulcers, where the ulcers are. If they're on top of the feet or in between the toes, it could be from arterial insufficiency or peripheral artery disease. If they're on the bottom of the feet, it's more from diabetic neuropathy. A lot of times also with the weak pedal pulses, we may not be able to feel them, but if we get out our Doppler, we can use our Doppler to hear the pulses, to hear the blood flowing weakly to that extremity. All right, so this slide, the one on the left, is an example of an arterial ulcer. See how it's bright, wet red, and it's well demarcated on the edges. There's really no peri-inflammation or anything. It's almost like a hole punch out of the skin. And again, it's on the top of the foot. The picture on the right is really a depiction of that hyperemic or that red, that purple color that happens to the feet with peripheral artery disease when the feet are down or dependent, okay, because gravity's trying to pull that blood flow down. Another really interesting thing about this picture is that a patient can have peripheral artery disease in one limb and not the other. Okay, so the limb that's more of that reddish color is the limb with a more severe case of peripheral artery disease as compared to the other. So the signs and symptoms of peripheral artery disease. We talked about some of them already in the first couple of slides, but some other signs and symptoms of acute ischemia is what we call intermittent claudication. And intermittent claudication is like angina pain to the heart. Okay, it's that that movement of those muscles in the lower extremities or the walking causing that increased oxygen demand and then causing pain in the muscles. And we call that in the lower extremities intermittent claudication. It does happen with prolonged activity. If the patient rests, then the oxygen demand goes down and the pain gets relieved. Again, if we go back to coronary artery disease, then we call it angina pain. Okay, when there's blood flow blockage in the heart, the coronary arteries, we have increased oxygen demand to the heart muscle. It's not getting oxygenated, it causes pain. Okay, so same thing happens in the lower extremities. We just call that intermittent claudication. And this pain can feel also like a cramping or a heaviness in the muscles. And again, it's relieved with rest. Now, we also go through the 5 P's, okay, signs and symptoms of total occlusion of blood flow to the leg. This is called vaso-occlusive disease, and it basically means that there's no blood flow. Okay, we assess the 5 P's. And again, intermittent claudication and these 5 P's are signs of our very chronic peripheral artery disease. So the 5 P's are pallor. Okay, so the legs are very pale. Pulselessness, paresthesia. They're very cold to the touch. Okay, and then paralysis is a late sign. So basically, when we see these things in an extremity, there is no blood circulation. As for diagnostic testing for peripheral artery disease, it starts with an ABI, an ankle brachial index. So when a patient comes in and complains of symptoms like heaviness in the legs or pain in the legs, that pallor or that purple color, maybe pain with walking, and the patient has risk factors, then we'll go ahead and screen them. So what we do for this is we take the blood pressure in an ankle and the blood pressure in the arm, and we compare the two. A lot of times, because of decreased circulation in the lower extremities, we may have to use a Doppler. And a Doppler is just measuring the pulses, okay, or the blood pressure with that ultrasonic device. Okay, so the Doppler in this picture that you can see, and we have the blood pressure cuff on the ankle and the blood pressure cuff on the upper arm. The Doppler really takes the place of the stethoscope. So we just use a Doppler to take the blood pressure reading. When we do an ankle brachial index, we're measuring the systolic blood pressure of the arm and we're measuring the systolic blood pressure of the ankle, and then we're dividing the two. In a normal physiology, the ankle systolic pressure is going to be higher than the arm. So we have our two systolic numbers in the arm and the leg, and we divide them. All right, so to calculate the ABI, we divide ankle by arm. If the number is greater than 1, the patient is fine. Okay, no peripheral artery disease. If it's 0.8 or less, then they are positive for peripheral artery disease. And this ABI is really pretty diagnostic for peripheral artery disease that has occurred somewhere in that leg. You know, there's a partial occlusion of blood flow. There's an arthroma formation somewhere in that leg, and it's causing that decreased circulation. A drawback of the ABI is that this reading doesn't tell us where the occlusion is in the leg. Okay, it tells us we have an occlusion, but it doesn't tell us where. So then we need to move on and do some more conclusive testing. All right, so we can do a Doppler ultrasound, and this is just like a cardiac Doppler that we talked about, and it watches the blood flow through the lower extremities. We usually use the femoral artery in the groin, the blood flow is usually decreased, okay, in the femoral artery in the groin, behind the knee also, and those are the two most common places that we would look at on the Doppler ultrasound. Now the colorful red image, the red, orange, yellow, okay, image here, okay, is the blood moving through the arterial system in the Doppler sound and in the Doppler ultrasound. So then the blue, green, and purple is blood flowing back or mixed together, okay, or sloshing around in the vascular system. So with these, so you have blood moving forward, you have blood kind of moving backwards and sloshing. You can see also in this picture where the blood flow gets very narrow. Okay, so with a Doppler ultrasound, you can see where, in what vessel the occlusion is and how much blood is flowing through those vessels. We can also do a peripheral angiogram, and this is done in the cath lab as well, just like a cardiac angiogram. We inject dye and watch the blood flow or where the blood gets backed up. All right, so you can see that depicted here in A or B. So in A, you can see that that's pretty normal blood circulation. In B, all right, you can see kind of in the popliteal or behind the knee where, you can see the blood flow in that right leg coming down the femoral artery, but then it kind of gets stopped in things in the, where the popliteal is. And then it kind of looks all white and stuff down at the bottom. All right, so where all of those vessels have maybe tried to bypass and you have some collateral circulation. Another interesting thing on this slide is you can see where it looks like they've had a fem-pop bypass, okay, in that left leg. So an artery that goes from their femoral to their popliteal artery to bypass some severe stroke. We can also do some different blood tests, okay, on someone with peripheral artery disease to check what their lipid levels are, to check their glucose, and also their renal function. As for medical interventions, treatment is really similar to coronary artery disease as well. We can use aspirin and Plavix. Okay, Pletal also does a really good job at vasodilating, and it's also an antiplatelet, so it is very helpful in peripheral artery disease. So we want to go ahead and put the patient on some type of antiplatelet. Pletal is usually one that we'll see for peripheral artery disease. Prentol is also a medication that you might see in peripheral artery disease because it binds to the membranes of the red blood cells to make those membranes a lot more slippery and pliable, so they can almost fold over onto themselves and move through that partially occluded vessel better. If the patient is in a vaso-occlusive crisis, so if the blood circulation is really, really decreased and it's almost, cut off to the lower extremity, and they have those 5 Ps, then radiology may inject the patient with TPA. And the TPA is done to dissolve a clot. It's not used very often for peripheral vascular disease. It's usually used more for coronary artery disease, okay, to avoid stroke. And also, we can put the patient on statins, okay, to make sure that where their lipids are down, because again, the arthroma formation, and then antihypertensive to monitor their blood, or to bring their blood pressure within a normal limit. Okay, if more signs of ischemia, if the patient has a lot more signs of ischemia, then we do more procedures to reestablish the blood flow, like an angioplasty, okay, of the occluded artery. So especially if they have those 5 Ps, we're going to go in, we're going to do angioplasty, and it's very much like angioplasty for coronary artery disease. We can also do a bypass of the artery in the leg, just like we would in the coronary system, and that's the FEM-POP bypass, which is the most common. That graft of a vein that goes around the occlusion. So if you remember back to the picture I showed you, it looked like they had some type of FEM-POP bypass. You could see that vein with the blood flow going around that occlusion. In some cases, the patient's blood flow may be so severely occluded and they have that paralysis, the numbness, and the leg is just not salvageable. All right, no blood flow, so we might have to amputate, okay? Because if we don't amputate, then there's more damage being done to the body. All right, so this is gangrene. Okay, so the picture on the left of your screen is a gangrenous toe. You can see that necrotic black, and it has like a greenish color to it. This is a gangrenous toe. It's developing an infection, or it's even starting to putrefy a little bit. So if we were to leave this toe alone, it would fall off on its own, or more likely it would spread that infection into the bloodstream, causing a systemic infection and possibly sepsis. So what we do in the case of, gangrene and necrotic tissue death of extremities because of lack of blood flow, in an extreme case, is an amputation. So we would amputate the toe. With an amputation, they try to salvage as much of the tissue as possible. All right, so nursing interventions for peripheral artery disease. Again, monitor, perform, and then teach. All right, so we monitor the 5 Ps. Okay, it's very important to make sure that blood still is circulating to those tissues, okay, somewhat. It may be diminished, but we also want to make sure that we watch to make sure that it's not, that the blood flow is maintained and it's not diminished. We want to check for signs of ischemia. We want to check for ulcers, for cracks in the feet. We want to make sure that the patient can wiggle their toes, checking the pulses, making sure that the feet are nice and warm. Okay, those are all signs, those 5 Ps, that chronic ischemia. We want to monitor the response to exercise. So, for example, if the patient can walk 150 feet, they have no intermittent claudication today. Tomorrow they walk 150 feet and they start to have, a problem or some intermittent claudication, then that is a sign that the peripheral artery disease is getting worse. So we want to monitor the response to exercise. We also want to monitor smoking and help educate to quit smoking. Quitting smoking is one of the most important risk factors, or smoking is one of the most important risk factors for peripheral artery disease, even more so than coronary artery disease because of the vasoconstriction and blood pressure issues that smoking can cause. It really, when we talk about peripheral artery disease, it doesn't really matter how much of everything else that the patient does. If they don't stop smoking, the peripheral artery disease will progress. So we need to work with them, as I said, to help them quit smoking. We can give medications to help in this process, like Chantix and Wellbutrin and things. And we also want to send them for counseling, to work with a counselor, again, to make sure that they're successful in their ability to quit smoking. Exercise is helpful, okay, in a very highly structured environment, to ramp up tolerance over time or to increase exercise tolerance. So now with the smoking cessation, I kind of switched, and then the exercise, I'm into more of the perform. So we had the monitors, and now with the smoking cessation, with Chantix and the patches and gums, we're into the perform. And then, like I said, the supervised exercise program. We want to make sure that the toenail care, because of those ram horn toenails, are done. But nurses should never cut those thick toenails, okay? They need to be done by a podiatrist or an advanced practice registered nurse, because a lot of times they need a Dremel or to drill them down, and different things, to monitor. So nurses or aides, unlicensed people, do not cut the toenails somebody with peripheral artery disease. We do not apply TED hose, okay, and we do not elevate the legs above the heart level. And the key here is we want to maintain as much blood flow as possible. So to have gravity helping us with blood flow is good. And then TED hose can cut off circulation. Okay, they're good to help with with heart failure, to decrease that congestion of extra fluids in the legs. But with somebody has peripheral artery disease, they can cut off blood flow even more. So we avoid their use. And then the last thing is teaching. So we want to teach the patient anything they can do to decrease their cardiovascular risk factors overall. Okay, absolutely no smoking. Okay, and again, monitor smoking level and then teach on avoidance of smoking or to quit smoking. If they have coronary vascular disease and coronary artery disease, then they probably do have peripheral artery disease. We do not want the patient, okay, in these situations to cross their legs, to stand or sit for long periods of time, tight clothing, tight shoes, to walk bare feet because of the decreased circulation that happens. We don't want the patient to injure their feet, or if they step on, something on the floor, something could embed in the bottom of their foot and then they won't notice it's there. That can cause an infection and other issues. And never use a heating pad. If a heating pad is used on the lower extremities, again, because of the patients don't have the ability to sense heat or sense pain. The feeling is decreased to their lower extremities. They can really be at risk for burn because they won't realize that their skin is actually burning from the heating pad. So don't walk barefoot and do not use heating pads. Okay, and then we also want to make sure that we instruct the patient always to inspect their feet every day. All right, to look at the bottom, they can get a little mirror, all right, or a long mirror to look at the bottom of their feet to make sure that there's nothing embedded, make sure there's no cracks, there's no sores, to keep their feet nice and clean and dry, to lotion, okay, again, to make sure that there's no cracks or peeling or anything that would promote an infection. Okay, so last topic in this cardiovascular disorders lecture is atrial fibrillation. So here is the pathology on AFib. AFib is very common in older adults. Okay, it is an irregular cardiac rhythm caused by multiple ectopic points of automaticity in the atria. Okay, so ectopic again means not in the right place. Points of automaticity are cells in the atria that are trying to trigger a beat. So both the right and the left, but mainly the right is usually the point of automaticity. And it's basically little areas of cells that are trying to trigger their own heartbeat, okay? Or they're trying to take the place of the SA node. Normal sinus rhythms originate in the SA node, and the SA node is the only spot in the right atria that is powerful enough to kick off a beat to go to the AV node. The SA node is the king of the castle. All right, so these other little cells, they're trying to kind of almost rebel, okay, against this SA node, okay, and trigger their own little beat. The problem is that all of these little beats or these little triggers and stuff that are happening are not in the right place. They're ectopic and they're not strong enough and they're not coordinated enough. Rather, they're all too random and they make their own little impulse, okay, that never makes it to that AV node. So we have an accumulation of all these random firings, and some may get through to that AV node, but not all of them will. So random energy also getting to that AV node causes that very irregular heartbeat. On an EKG, we'll see a very random QRS complex, okay, or random ventricular contraction. Okay, so that means that that QRS complex is very irregular. Okay, so to answer the question on the slide, normally the only point of automaticity, okay, is the SA node, and that is in the right atria. Okay, so here is just a depiction, again, of the pathophysiology of atrial fibrillation. So the picture on the left is a normal heart. So the SA node is usually what is triggered, and it coordinates the electrical current into the AV node that spread to the rest of the heart for contraction of the heart, okay? And you can see the strip below would be a normal sinus rhythm. So the picture on the right, you have those random triggers, okay, in that sinus node and in that AV node, okay? You see all of that random stuff going on there. And that triggers irregular QRT complex. Okay, so you can see that irregularity in the strip below the heart. There's some long spans, you know, in between those intervals. There's some short spans. It's kind of just all over the place. So that's the irregular heartbeat that is caused from atrial fibrillation. So AFib is not necessarily a problem on its own, okay, as long as the older adult can maintain their blood pressure and there's no clot formation that happens in the atrium. All right, so we have these random firings, but the heart is beating, it's just beating irregular. Not if it doesn't cause any problems, we don't always treat it. We just kind of leave it alone. But there are two major complications that can happen. Okay, the first one is unreliable ventricular rhythm. The heart will beat too fast and it'll beat too slow. There's no rhyme or reason to the beat. The ventricles in this case may not be able to fill. There's decreased cardiac output if there's too fast or the heart rate's too slow. In these things, this unreliable ventricular rhythm, there's always an irregularity or an irregularly irregular heartbeat. It's never a normal, regular heartbeat. There's also unreliable atrial emptying. Okay, so the two major complications are unreliable ventricular rhythm. Okay, too fast, too slow. The ventricles can't fill, they can't empty. We have decreased cardiac output. There's also unreliable atrial emptying. So if the atria can't empty all the way because of the irregular beat, then we have pockets of blood kind of sloshing around, okay, in the atria. And what can happen is they can clot, and that clot can embolize to the brain. Okay, and that's kind of what the picture then at the right is depicting. So as for signs and symptoms of atrial fibrillation, older adults often complain of fluttering in their chest, or they may feel like their heart is racing. And these are usually the two complaints that will bring people into the emergency room or into the physician's office, or that you'll hear. Also, they could have syncope or near syncopal episodes if they go into kind of an exacerbation of atrial fibrillation. They can have fatigue, chronic tiredness, weakness, etc. An AFib exacerbation can also cause more confusion because of the inability of the heart to pump well enough because of those ectopic beats, and it causes lack of blood flow to the brain. So the patient can be a little bit more confused. They also may have a recent history of the things that are listed on the right side of your screen. And these are like triggers. So high caffeine use, using decongestants, binge drinking, heavy caffeine use, okay, those as smoking, okay, could be a trigger of atrial fibrillation. Beta blockers also must be tapered down. Okay, so we always want to instruct a patient never just to stop taking their beta blocker. We use a 12-lead EKG to diagnose atrial fibrillation. So in order to actually diagnose, they have to have a 12-lead EKG at some point. The classic AFib findings, okay, are here on the slide. The characteristic findings, that missing P wave, that irregular RR intervals. We showed a strip a couple slides ago that had those. Proximal AFib is sudden episodes of AFib that resolve spontaneously, and that's common. These are the things that usually cause those syncopal or near syncopal episodes. Patients black out and they fall. An EKG is really a snapshot in time. So if we just do an EKG, we can miss some AFib episodes. So it's better often to do a Holter monitor. And a Holter monitor is really just a portable EKG that's worn for 24 to 48 hours. It stores information in a computer chip, and that computer chip is then uploaded to the cardiologist's charting system. It's really a great test to see what the heart is doing. What the patient will need to do when they're wearing a Holter monitor, and the picture here depicts a Holter monitor, is the patient needs to record their activity. okay, while they're wearing the heart monitor. So here's again a picture of a couple strips, so a bigger picture. Okay, so the top strip here is a normal heart rhythm. Okay, you see those RR intervals, and those spikes are at like the same distance. They're nice and regular. The bottom spikes are not equal distance apart from each other. There's really no pattern to it. This is what we call that irregular patterns, and is classic for atrial fibrillation. You also want to take note on this bottom one is that there are no P waves. On the top slide, just before each big spike, there's that tiny little bump, okay, that happens. Okay, so that tiny little bump that happens before that big spike. So on the one below, you don't really have that little bump that happens. Okay, so no P waves. As for medical interventions for atrial fibrillation, our first goal is to control the rate. Okay, so we want to slow the heart enough to get good ventricular filling, but not too slow that we cause a heart block. Okay, so we want to really control the rate. So we want to slow the heart down, but not slow it down too far. The best thing to do is use a beta blocker like metoprolol, or a calcium channel blocker like diltiazem. And these are usually given PO, although we can give them IV if it's an emergency case. Sometimes we want to control the rhythm. So we can control the rhythm with amiodarone or digoxin. But both of these meds are dangerous, and they both have a lot of renal issues. So sometimes we really forgo controlling the rhythm, rather we just control the rate. Every patient, whether they have a controlled rate, or whether we want to control the rate or their rhythm or both, we need to control for clotting. So the worst outcome of atrial fibrillation is a stroke because of the clots. So we want to control the clotting. The standard dosing is, one thing that we do is we provide warfarin. And that's a standard medication that we will see our patients on, so warfarin or Coumadin. But there's lots of monitoring that needs to be done. Okay, there's lots of drug interactions. We need to make sure that the patient has a consistent vitamin K intake. If it drops, or if the patient changes their diet, that can affect the warfarin levels in the blood. Warfarin needs to be taken at the exact same time every day. Also, and then we need to do daily to weekly blood checks to see what the level is in the bloodstream. We want to always keep the INR between 2 and 3. So when a patient starts out on warfarin, we may have to draw their blood and check those INR levels every day. Okay, then once they start to stabilize, we might decrease our lab draws to once a week, once a month, and maintain them on a dose that's going to keep their blood levels consistent to prevent clot. So what a lot of practitioners are doing, instead of the warfarin, since there's so much monitoring and so many side effects, and as I said, it is a standard treatment, but a lot of providers are going more with the novel oral anticoagulants. And the 3 main ones I have listed on the slide, these are taken once a day. They have a much safer bleeding profile. They have fewer drug interactions. They're more stable, and you provide more consistent blood levels than warfarin does. There's really no need for the patient to change their diet. We don't need to monitor INRs. One of the important things is that we do need to still take them at the same time every day, and that's important instruction to give to your patient. They're a lot safer, and they're a lot less trouble, and they work at least as good as warfarin does to prevent stroke. One of the downsides of some of these medications is they can be very expensive. I'm going to talk about synchronized cardioversion here on the next slide as a way to control the rhythm. So synchronized cardioversion. What happens is that we really deliver a shock at a specific time that stops that electrical activity, and then it resets that SA node, okay, to get that heart beating regular again. So if we're going to cardioverse someone, we put patches on their chest and we hook them up to a defibrillator. The defibrillator then senses the R waves, and it detects when those R waves are occurring, and the defibrillator will then deliver a shock synchronously with the R wave, okay, to get the heart back into a regular rhythm. Just a little bit back to like the currents of the heart. So when you shock the heart at the top of the R wave, it resets everything. It cancels out the rest of the beat and restarts the heart at that SA node where it's supposed to start. Cardioversion is really a way to stop the heart and then restart it in the right place at the right rhythm. Problems with cardioversion then are that it's painful, so we have to sedate the patient and provide analgesics. If we do this and there's those clots in the atria can also dump out those clots. Okay, so we have to usually do things to make sure, like an echocardiogram, to make sure that there's not any clots in that atria before we do the cardioversion. Okay, so sometimes we may need to delay the cardioversion or put the patient on a heparin drip, give those anticoagulants before we actually cardiovert someone. So if we do cardioversion electively, we can schedule, it electively, so it's convenient. If it's an emergency, though, what usually happens is we start the patient on a heparin drip, and then we do a quick echo to look for existing clots, and then we cardiovert. All right, so nursing interventions: monitor, perform, and teach. All right, so we want to monitor, we want to do a really good cardiovascular assessment. We want to monitor the rhythm, asking about, any fluttering, any lightheadedness, the heart rate, do bedside telemetry to monitor the rhythm. If, we want to monitor the heart rate. If it's slower than 60 or higher than 100, there may be a problem. So we want to monitor even closer. Want to monitor for bleeding, especially if they're on Coumadin or warfarin. And we want to monitor the INR and also signs of a stroke because of growing clots due to the atrial fibrillation. I want to just back up. One thing I forgot to mention about warfarin is the patient, we want to make sure that we monitor for bleeding as well. So we want to watch for petechiae in the skin or bruises that just pop up, bleeding gums, bleeding nose, maybe bleeding hemorrhoids. Anything that's going to tell us a sign that the blood is getting too thin and the patient is bleeding. Bleeding precautions a lot of times can be followed as well. So we want to make sure that, we tell the patient to remove coffee tables in the home so there's no sharp edges. Don't use a razor, to cut yourself, those types of things. I'm sure you've learned about those in med-surg as well. So we want to perform, we want to administer medications, and we want to make sure that those medications are given on time, especially beta blockers or calcium channel blockers. Giving the DIG, is very important, especially at the same time every day. Because DIG has an exact 24-hour half-life. And if that half-life, we don't give it on time, that effective dose in the blood plasma drops, significantly, and the patient can go back into atrial fibrillation because we didn't administer that digoxin on. We want to monitor heart rate. okay, because these drugs can cause a heart block. Okay, they can lower heart rate. So if the heart rate is less than 60, we usually hold the medication, notify the physician, and document, and then the physician will direct us what to do. We want to make sure that the patients are on fall precautions, the bleeding precautions I talked about, talking about advanced directives with them. Okay, always important to talk about advanced directives, especially early in the course of any type of chronic condition. And then last slide, we want to teach the patient to avoid triggers, okay, that can cause atrial fibrillation. Those triggers that we talked about already, like alcohol or smoking, okay, caffeine use. We want to teach about the signs and symptoms of a stroke, especially with that FAST acronym. So face, arm, asymmetry, blurred speech, and then call 911. If the patient starts to feel their heart fluttering, or racing, what do we want them to do? Okay, we want to teach how to check for their pulse. Want to educate about medications. What do they do if they're symptomatic? They feel their heart fluttering or racing. Okay, they should lie down. Avoid that Valsalva's maneuver because that can lower the heart rate anymore. When does the patient call the cardiologist and when should they call EMS? Okay. And then the importance of follow up. Okay, it's very important to follow up with the cardiologist at the clinic. Okay, is extremely important. And then also if the patient's on warfarin, to follow up with the warfarin clinic. And that is the end of the cardiac lecture. After you guys listen to this, if you have any questions, please go ahead and shoot me an email with your questions, or we can meet via Zoom. I would be happy to make sure you understand the cardiac portion for the exam.